Hello, everyone. My name is Efa Moranta, and I'm a family nurse practitioner student from Franklin University. Today, I'm going to present to you a very common case in our practice, which I hope it will be very helpful in our future practice as a family nurse practitioners. This is a 21 years old male with not past medical history reported, which present to our health center today with abdominal pain that has been migrating from the epigastrium to the right iliac fossa, accompanied by nausea and vomiting of food content, also known as a morphine triad. Also, patient report that was working at McDonald's when the pain started. At the beginning, the pain was mild, rating 3/10 in pain scale. But right now, after 6 hours, patient report the pain as a 15/10 in pain scale. And he said that is the worst pain in his life. Patient also report to be very cold right now, even the temperature is 80 degrees outside. On physical examination, patient denies any allergies to medication. The vital signs, they're all under normal level except for temperature, which is 100.2. Also, the oral mucus is dry. We can notice marked skin pallor. Patient is on antialgic position and with positive Dilafoid triad that is consists in skin hyperestasia, reflex muscle contraction, and pain at mid-burning point, which is located on the lower third between the umbilicus and anterior superior iliac spine. Also, during the physical examination, we also perform Blumber and Robson test, and it was positive sign, and that consists in decompression of the left iliac fossa, and the patient is going to feel that very severe pain on her right iliac fossa. In our clinic, we try our best to perform some kind of test. Sometimes we don't have all the equipments, but here we could perform a CBC, which reveal an elevation of white blood cells at 14,000 to neutrophil expensive. Also, patient was positive for C-reactive protein. The urinalysis was normal, and liver and pancreatic tests were negative. We also perform an ultrasound. We show tubular thickening with 9 centimeters structure in the right iliac fossa. At this time, we can have some kind of differential diagnosis. The first one that I could think is acute appendicitis, also right renal lithiasis, diverticulitis, urinary tract infection, pancreatitis, cholecystitis, and perforate duodenal ulcer. The suspected diagnosis is probably complicated acute appendicitis. As a treatment plan, first of all, what I can do is the patient must be transferred immediately to the nearest emergency department of our center, which is why we have called already 911. We have placed also an intravenous acids route with normal saline 9% solution to correct the hydroelectrolyte imbalance. And we also started MPO diet as soon as the ambulance arrived to make the transfer. We will not treat the pain at this time because we don't want to mask the picture. Other studies will probably be carried out in the emergency department. Also, the doctors there might evaluate the possibility of antibiotherapy, and also the probability of an